This is CGTN, China Global Television Network.
Hello and welcome to this Razor COVID-19 special. I'm Shini Somara. Children are the least affected by COVID-19, but a seemingly new condition has health professionals worried. It's called Paediatric Inflammatory Multisystem Syndrome and causes inflammation in blood vessels and in some cases attacks the heart. It's being linked to COVID-19 because children with the condition are carrying IgG antibodies, an indication that they've previously been infected with the coronavirus.
So both the temporal association of about 4 to 6 weeks after the peak in the general population of COVID-19 infection itself, plus the fact that we're finding these IgG antibodies in these children who are having this peak incidence of this multisystem inflammatory syndrome 4 to 6 weeks later than the general population, makes us think that this is, well, we know they're not actively shedding virus, makes us think that this is most likely, although this is the leading thought, it needs to be studied. This looks awfully similar to what we call a post-viral syndrome.
Initially, we couldn't quite figure out if it was related to COVID-19.
We know that it's temporally related to COVID-19 in time. We know that it's related to COVID-19 because the children have antibodies, these IgG, but we know that they're experiencing different kinds of symptoms, the Kawasaki, especially in the Italian experience, where they saw an increase in the number of children who are presenting with Kawasaki disease or Kawasaki symptoms per month. They normally see about 3 per month in northern Italy, and now they're seeing 10 per month. And so, when you use the term, is it related, from a medical scientific perspective, you'd say, well, COVID-19 is not necessarily causative. The virus itself is not causative of the infection because the virus is not there. Instead, in medical scientific terms, you'd say there's an association. There's an association in time, but that if the thought is right, the inflammation, the fever, the inflammation the child is experiencing is not driven by the virus, it's driven by the antibodies that fought off the virus.
Should parents be concerned about their children when they thought, they weren't going to possibly suffer from this, and now we're hearing about this inflammatory disease? I mean, how rare is this disease?
If it's your child, it doesn't matter if it's rare. What I would say to parents is this multisystem inflammatory syndrome is not a subtle presentation. You can rest assured that you have all the tools you'll need to spot this. You know your child better than anyone, and it'll be clear that your child has a persistent fever, greater than 38 degrees Celsius, centigrade, for over a day. And that persistent fever will be accompanied by one of or more of the following: a rash, abdominal pain or discomfort, difficulty, labored breathing, not having a good appetite. In some, it'll look like they have a bad influenza virus. So it won't be subtle, and it doesn't come on rapidly. The other thing I would say is that right now at the Morgan Stanley Children's Hospital in the middle of Manhattan, New York, it's the largest children's hospital in New York City. They have about 35 children admitted in the hospital with this syndrome, this multi-system inflammatory syndrome, but almost all of them are being treated on the ward, the floor. They're not being treated in the intensive care unit. So it's not at all similar to what we're hearing about how terribly sick adult patients are getting. But it is true that there are a few critically ill children from this in other hospitals in New York right now and in the city of Detroit in the States. And I don't doubt that there's likely 1 or 2 critically ill children in Western Europe, probably in an ICU on a ventilator right now from this syndrome. But again, if we look at all of the children under the age of 14 in Western Europe, That's millions of children who don't have this disorder.
Is this syndrome affecting, any particular, is it boys or girls, as we're seeing with, men and women in COVID-19? Is there a particular age group? I mean, can you sort of draw any conclusions there?
The preliminary information would indicate that this by and large affects school-age children and adolescents. So far, it doesn't appear to affect infants to that same extent. In terms of gender, so far, more males have been reported as having this than females, but we're going to have to wait for more refined analysis. And it's unclear whether there's a genetic predisposition to this and whether certain racial groups, there's a suggestion that it might be so, but I'm hesitant to go any further because we're so early on, we don't know. But for what I can promise parents out there, we are looking as fast as we can to try to figure this out.
You had a Zoom conference. How many people from around the world were joined in from the different countries?
1,800. There would have been more, but they got kicked off. We've been having a conference call with doctors, specialists from the probably 150 largest children's hospitals in the world across 6 continents. I asked them, can you update us as to whether there's any critically ill children in your ICU in your pediatric hospital from COVID-19 or from this? And so we've been doing this since March 14th. And the US CDC, the WHO, the European Commission have all asked to join on. And of course I want them on. And one of the alerts that we put out was that for the children presenting with multisystem inflammatory syndrome, that clinicians should be very careful to draw blood or serum, plasma or serum, before they initiate therapy, so that we can get a picture of what was their immune response doing to produce the fever and the other symptoms that have brought the child into the hospital. Not only to understand the multisystem inflammatory syndrome, but as I said, those antibodies are clearly linked to fighting off COVID-19 in that child 4 to 6 weeks earlier. So this is now key to understanding how are they able to successfully defend against COVID-19 so well, but why did they have this accelerated reaction 4 to 6 weeks later? And that in turn will be important to vaccine development for children.
As we wait for a vaccine, trials are underway to see whether existing drugs can alleviate coronavirus symptoms. Emma Keeling spoke to Dr Nick Cammack from the Wellcome Trust research charity.
So the Covid-19 Therapeutics Accelerator was set up very quickly after we learnt about this infection. It sort of parallels an organization called CEPI, Coalition for Epidemic Preparedness Innovations, which focuses on vaccines. The Therapeutics Accelerator focuses on drugs. To tackle this virus, we need both. We need virus treatments and we need vaccines. Really to accelerate, hence the name, treatments for this infection.
Are we seeing unprecedented collaboration between scientists and researchers around the world?
Yeah, I was involved many years ago when HIV came to the fore, and the enormity of the problem pressurized groups that wouldn't normally get together, so activists and pharmaceutical companies, really to get in the same room and move that challenge forward. And I think we're seeing exactly the same here in the COVID-19 pandemic. Governments, foundations like ourselves, private companies, all getting together to try to tackle this pandemic as quickly as possible, which is brilliant to see, I have to say.
Do you think this has been a wake-up call for governments in terms of maybe the funding that they're putting into science? Do you think there could be a change?
Well, as a scientist, I want lots of funding into science. I think it is really showing the importance of scientific understanding. Like HIV now, we know lots about it over many years. But here's something that just appeared months ago, and we're all having to learn very quickly, and that's science that you need to do that, whether it's basic science, clinical science, and frankly, social science.
So how many possible COVID-19 treatments is the Accelerator Group funding? And I guess there's a lot of other ones going on around the world as well that possibly the Accelerator Group is not involved in.
We're looking at probably a dozen as potentials for evaluating, but there are clinical studies around the world of probably now around 50 or so different medicines just to see if we can ameliorate the disease somewhat. I think when those clinical studies give their results, we'll be able to then do larger clinical studies across the whole world to really understand their benefit and then roll those out as treatments. And we'd like to try and do that during this year. We set ourselves an aim in the Therapeutics Accelerator of 100 million treatment doses by the end of this year. That is a ridiculously ambitious goal, but if we don't have a goal like that and we don't work differently, we will not tackle this infection in good time.
But you're also dipping into, the development of vaccines as well, aren't you? A couple of situations in Pennsylvania and the US, I believe.
So Wellcome funded CEPI with £100 million. CEPI is a separate entity and is very focused on epidemic preparedness. So this is exactly its sweet spot. And they have a team of experts who are looking at multiple different vaccines. Given the fact that we're in a pandemic, we need to evaluate many different approaches. We don't know yet which vaccine approach, and they're all subtly different, will win out and will be the best one for global use. So CEPI is investing in many different vaccine approaches. There are now, today, probably half a dozen in clinical trials, which is remarkable given that we only learnt about this virus, let's say in December in China. So there are half a dozen in clinical trials, but probably more than 100 vaccine candidates being evaluated in the preclinical, so before you get into man, preclinical stage, to check for their ability to generate an immune response.
So will this COVID-19 not be treated by one vaccine? There's a possibility that several vaccines could be used.
I think what we'll see is, as we see the clinical studies, we'll see the effectiveness of the different vaccines. And what is likely to happen, given the large number we're looking at, there will be some that have equal effectiveness. Some may work better in some populations than others. Some vaccines may work better in older people and some in younger people, for example. So really important to move many forward so that we are able to cover the global population, which is what at Wellcome we care about.
We know it's many months before we can expect a vaccine. Is there anything in the meantime?
I think what will come next will be monoclonal antibodies. So these are antibodies that have been developed from people who were infected with COVID-19, and imagine sort of large-scale production of individual antibodies that kill off the virus. I think they'll be the next treatments, and we'll see those going into the clinic in the next couple of months, and maybe early next year. Again, safety and scale up and effectiveness to be evaluated. Maybe early next year, we see those as the first specific treatments. So antibodies that stick to the virus and stop it infecting cells and spreading through the lung cells. Those could be real benefits quite quickly. And I do think we do need a treatment to bridge the gap between now and when we'll have quality vaccines, which I think we all want.
It's a disease that could attack anybody.
Life under lockdown.
And I'm Rahul Pathak.
It comes as a shock to all of us.
So I'm in home isolation.
I'm Isabel Ewing in Budapest.
We have a simple message for all countries. Test, test, test.
After schools shut their gates from Friday.
We are accelerating research.
I said very clearly there's more to do.
Develop a vaccine.
You were the eldest person to have survived this nasty virus.
Thank you so much for all you people.
Don't forget you can sign up to our daily newsletter. We bring you all the top business headlines straight to your inbox. So sign up for free at this address. CGTN. See the difference.
allegations that the coronavirus may have escaped from a laboratory or even been created are part of what's being called an infodemic of misinformation. Professor Susan Weiss has been studying coronaviruses for most of her career, but the one she's really interested in is found in mice, not bats.
Not only me, but the whole field worked on the mouse virus for many years, and all the basic mechanisms of how coronaviruses enter the cell, how they replicate, how they make their RNA, how they combat the immune system. A lot of that was done with the mouse virus, the bovine virus, the pig virus, the chicken virus. So they were really important, and that's before we knew about the pathogenic human viruses.
Can you describe the mechanism by which a virus that isn't pathogenic to its host, like SARS-CoV-2, becomes pathogenic to us?
I don't think we know exactly. I mean, one of the big questions in this field is why the bats don't get sick and the humans do. And there's a lot of speculation that it might have to do with the bat's innate immune system, that the bat has better host defenses so that it keeps the virus at bay so it can kind of coexist with it. The MERS coronavirus, for example, in camels, that's its reservoir. It causes a cold, but it's a very similar virus that makes humans very sick. We don't know why. Maybe in the camel, the virus stays in the upper respiratory tract. Maybe the receptors are not in the lung, but they're in the upper respiratory tract. We don't really know why. It's probably a combination of host responses, maybe receptor distribution. I mean, the bat virus, I believe in the bats, it's an enteric infection and not a respiratory infection.
You mean it's in the gastrointestinal system?
It's in the gut, and people find it in guano, in the bat poop.
Yeah.
So, we don't know.
What can we do to stop it happening in the future? Can we do anything?
I think the spillover comes from proximity. If bats are in proximity to these other animals, like civets, for example, I think it's the contact. I mean, I don't think there's another way to prevent that from happening because there are many, many, many viruses in the bats.
Your Secretary of State, Mike Pompeo, although he contradicted himself almost immediately, said that he thought the virus was manufactured. Do you think that's possible?
Well, first of all, I don't think that he's in a position to make that kind of decision unless he has some information that he's not revealing. And if he just has a hunch, that's kind of crazy. But I think that I don't think it's possible for someone, it's hard to say it's impossible, but it's nearly impossible, let's put it that way, that somebody could imagine how to put together the correct sequence of RNA or the correct genes to make such a virus that would spread asymptomatically, for example, compared to the original SARS spread symptomatically. So there's no way that anyone could imagine how to make a virus to make it like in a way spread worse than SARS. It's similar to SARS, but it's different. It's not like it's SARS with one little piece of it or one gene changed. It's like SARS that's different all across this whole genetic 20,000 nucleotides. That's a very long genome. It's the longest RNA genome we know. So it would be very hard to imagine that somebody would have the knowledge or the imagination to figure out how to make a virus that would be so destructive.
President Trump was a little more generous. He thought the virus might have only escaped from Professor Zheng Lixi's lab.
Well, I mean, that's a whole other theory. I think that's unlikely. I read somewhere that she had looked at all her sequences that she had of viruses in her lab, and none of them matched this new virus. And in fact, this new virus is very close to another virus called RATG13 that she's published on. But it's different enough. Again, it's so different across the genome that it can't possibly be the same virus. So I think, we work with these viruses under high containment, and I have no reason to believe that she doesn't do the same. So I think it's very unlikely. I think it's the kind of thing that I think the person who suggests that should have to prove it, like you're innocent until proven guilty, basically.
But that's the problem with these allegations, isn't it? It's impossible to disprove them.
I think it's impossible to disprove that kind of thing. I mean, there's no known virus that it resembles, but she hasn't seen that virus yet in her lab.
Yeah, that's right. It was new to her too, wasn't it?
Right, it was new to her.
Based on all of her publications beforehand.
Exactly. I think it's pretty unlikely, and I think that it's pretty irresponsible to go around accusing people of things like that when you have no information, really. Just a hunch.
Many people who should be going to doctors or hospital have been staying away because of COVID-19. Joel Dunning is a consultant heart and lung surgeon from Middlesbrough in the northeast of England. He believes now that the peak of the coronavirus infections has passed, we'll soon see a second peak, not of COVID-19 sufferers, but of extremely ill people who would otherwise have been treated.
Actually, what we saw as we got through the peak was on Easter weekend, in fact. There were 22 ventilated COVIDs and 150 people in our hospital with coronavirus. But now we're down to only 7 with ventilated coronavirus and only 50 in the hospital. So the peak's gone. And actually the new peak, the new need, the second spike that might come along is restarting the services we left behind. It's now 2 months since we were doing urgent lung surgery and heart surgery. And so now we're working really hard to try and restart that service, which is, I think, the new urgency.
Have we lost people as a result of the not being able to get what they needed, heart, lung surgery, because of the pandemic?
From very personal experience, every single one of our heart surgeons knows someone that's passed away on the waiting list now, which is, really tragic. There's actually been an up spike nationally in people coming with something we hardly ever see called left ventricular rupture. This is where someone has a heart attack, they don't present to hospital, and then they come in with the heart basically virtually exploding. Like, it's almost unseen normally because people come for heart attacks, but we're seeing a wave of these coming urgently. So that again indicates people are not coming for their heart attacks and maybe not getting surgery. On the cancer front, it's really eerie because our meetings where we'd go through all the patients with cancer, they're half the number of patients at the moment. And that's because we'd be expecting these people to be going to see doctors initially about 4 weeks ago. And yet that was the height of the lockdown. So people aren't coming forwards with their symptoms of cancer. And also half of our patients are picked up by luck when they're having a CT for something else. But nobody's doing CTs for the something else, the more benign things. So these things aren't being picked up. So, it's an eerie time. We know that nationally there's an increase in the number of non-COVID deaths as well. So I think we'll know in 6 months' time, but I do suspect that, there's going to be an up spike in urgent heart cases, and, cancers are going to come in a more advanced stage.
So those people who normally go, well, that's a bit odd, I better go see a doctor, have not been doing that because they've been in lockdown.
Absolutely. Yeah, 100%. People are scared. Patients are worried about even coming to have cancer surgery. They're worried about coming to hospital. So people are being told, it's in care homes and in hospitals where the coronavirus is. So people are really scared to come. People, you're meant to see a doctor if you have a cough for more than 3 weeks for cancer reasons, if you're a smoker, and yet nobody thinks of that anymore because all they think a cough is coronavirus. So they isolate and don't come to a hospital. Secondly, the GPs are seeing patients much less frequently. They're doing conference calls and not actually going out to people. So there's a myriad of reasons why cancers are not being picked up.
As we emerge from lockdown and begin to return to work, most forms of public transport won't allow for social distancing. So what to do? I think I may have found a solution. As we try to avoid public transport, that might mean more and more cars on the road. Bicycles are an option, but they require a certain level of fitness. But what about one of these? They're clean, they're green, and they're quick, but they are still illegal in some countries. Nationwide trials are soon to begin here in the UK to legalise them, which could provide an effective alternative to urban commuting.
The ban really, it's to do with an old law relating to motorised driven personal transport. Motorised driven transport requires insurance, it requires a licence plate, it requires a large helmet, motorcycles type helmet. So, which is why we now need this legislation to be passed here in the UK, so we can follow suit like has been done in France, in Italy, in Spain, in Germany. There are scooters everywhere. People are moving around. There is a movement towards this type of vehicle. With Germany really spearheading all of this in Europe. And now the need for people to move around cities, perhaps without the use of public transport, this is the right time for a product like this.
To ensure the safety of riders and pedestrians, an initial public consultation will set out to define an e-scooter's physical design, maximum speed, and power limits, as well as a range of rules for upcoming e-scooter trials. Once this has been decided, trials will see rental e-scooters allowed in various cities in the UK, but privately owned e-scooters will remain illegal to use until after the trial.
It's an exciting time for that. The public have been invited now to talk about, perhaps come up with some comments. What do we think here in Britain towards scooters being a legal product? People that have ridden shared scooters around the world are all for this as a mode of transport. So it is a great solution, and we have to see how that works out. But the challenges now for public transport and the way we are going to move around post-COVID-19, this is something that has to be addressed straight away. And I would hope that it's something that perhaps could be implemented largely by September of this year. But the rental model has got people on scooters. This has got hundreds of millions of people, millions of rides around the world, got people on the product, and they think, this is great. This is a great way to move around the city. I think for us, our model is based around ownership. And I think that, if we imagine how the world is going to change post-COVID-19, are we as likely to pick up a product that somebody else has had their hands on not 5 minutes before? We're probably less likely to do that.
The most familiar e-scooter design is similar to a push scooter. It has small wheels, which some people think can be a safety issue. John and his team have reimagined what an e-scooter could look like.
Our scooter is based essentially around bicycle principles. This is essentially an e-bike without a seat. So it's a natural product to ride. It's natural to stand on it. You don't need any training. It's stable and it's safe. That geometry that we've used, proven geometry from bicycle setup, works when you stood up. It's a safe solution. It's nimble. You're in and out of traffic, but you're safe and you're visible. And that's the important thing. It's a visible product because it's notably larger than what is currently available on the market.
Why has London, with so many people trying to commute on a daily basis, been so far behind on the e-scooter bandwagon?
I think this really relates to the infrastructure within the cities in the UK. London is an ancient city. It's been there for a long time. The road network has been there for a long time. It wasn't even necessarily geared up for cars, if we really look at it. They're not particularly wide boulevards, really. Currently, we don't have the cycle lane in the same way that they do in Europe. But I think that, the introduction of cycle lanes and a proper part of the road for micro-mobility, this is going to change everything moving forward.
In London, a £250 million emergency active travel fund has been announced. This will be put towards the construction of pop-up cycle lanes, wider pavements, safer junctions, and trial e-scooters. With car use down during the pandemic, cities across the world are implementing similar schemes and reallocating road space for pedestrians and people on greener modes of transport, such as bicycles, electric bikes, or e-scooters.
It's not been something that hasn't been able to have been done before. We've managed this in a couple of weeks. So it's very exciting now that that's starting to happen, and it gives that safer environment. It makes the rider feel safer, that they have their own part of the road, essentially. Bicycles and electric scooters have as much of a part of transportation going forward as any car or buses. But the reality is that a post-COVID world in transportation is a totally different world. I've never seen the sky so blue. And I'm not the only person. The lack of petrol motors on the highways has made a huge difference. And actually, for the first time, rather than people talking about it, this is what's going to happen. We've seen it ourselves.
That's it for this Razor COVID-19 special. Stay safe, look after each other, and we'll see you next time.